Sabay-sabay tayo yumapak sa landas ng medisina. Sabay nating hinarap ang pagsubok at paghirap, hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, natin adhana bilang ating sentenaryo, ay biglang natapos din 5 taon ng pagsisikap, 5 taon ng pagsasama sa oras ng saya't hirap. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH. Ay busilak ng utak at puso, kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, may laban sa utak at puso. Sabay-sabay tayo yumapak sa landas ng pagkakaisa. Sabay nating harapin tagumpay ng ating mithiin, karangalan at galing sa lahat ng ating gawain. Magsikat ng liwanag sa bawat araw ng taon, pasalamatan natin Diyos na Panginoon, sa alaala at kwento na
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still Primary Healthcare in the Era of Universal Healthcare. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, we encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Good afternoon, everyone on Zoom and those watching the Facebook and UP Manila live streams. Before we proceed, let me introduce myself as your moderator today. I am Dr. Dennis Sakdalan, an associate professor at the UP College of Medicine and the unit head of the Manila Med Cancer Care Center. I'm also a member of this year's Silver Jubilarians UPCM Class 1998. Today is an extra special webinar because we have invited two experts in the field of lung cancer. Because incidentally, it's Lung Cancer Awareness Month in case you have not heard. Our first speaker is Dr. Ralph Villalobos, an interventional pulmonologist, and also from UPCM Class 2011. Also joining us today is Dr. Rich King, adjunct professor at UPCM, affiliate physician and junior faculty at the Division of Medical Oncology of PGH, and also a member of UPCM Class 2014. Today, the benefit is screening and surveillance of lung cancer. So I give the floor now to Drs. Villalobos and Dr. King.
So good day, everyone. I'm Dr. Ralph L.V. Villalobos, and we welcome you to this UPMAS webinar for a very important topic and I think, very timely, and one that is very, very close to our heart. This is lung cancer. And right now, our main objective actually is to tell everyone, the audience, that lung cancer is not really a death sentence as what we have in the past, experience in the past, wherein it was really it has a grim prognosis. But for today, we'll be focusing on the benefits of catching lung cancer in the early stages, and of course, how to do that and how to do the surveillance for this very common disease, and of course, very, very treatable disease. And with me today is an esteemed oncologist, which is also our partners in treating for lung cancer in the Philippine General Hospital and in other hospitals, Dr. Rich Erickson King, and of course, Dr. Den Sakdalan will be moderating this session. So these are the disclosures of the team. So I received honorarium from Roche, and I do clinical trials for the other vaccines that are in development. And this is Dr. Rich King's disclosures. He has no disclosures. And of course, this is Dr. Sakdalan's disclosure as well. Okay, so this would be the outline for our talk today. So we would be presenting actual patient cases of early stage lung cancers. So we would like to give some hope on people that lung cancer, if detected early, can actually be curable. Okay, of course, discussion on risk factors and epidemiology of both local and international data for lung cancers, and presentation of the traditional approach to treatment, and of course the new approaches to treatment. So as I may say, lung cancer really is the one disease of all the cancers that the treatment regimen and the treatment plans and the treatment landscape has changed from 10 years ago to now, and the prognosis as well has improved a lot. Okay, so these are the disclaimers. So this meeting, there will be discussions on ongoing or completed phase 1 to 3 trials of new drugs and indications from any pharmaceutical company. And these are for consultation purposes only and should not be construed as off-label or pre-approval promotion. For some drugs, the PFDA has yet to review and approve such in terms of efficacy and safety. And of course, we have to be cautious about off-label prescription until the FDA has given its approval for the use of the indication in the Philippines. So I'll start off with a actual case. So all the cases that I will be presenting today are actual cases, and just to tell you that actually this happens, the good news happens, or the good cases happens in real life. So I'll start with a 53-year-old male. He is an executive producer from a local media network. He is a heavy smoker. And mind you, he really smokes a lot, around 100 pack years. And during the time he consulted me, he was actually heavily smoking as well. He has no other comorbids and no family history of cancer. And the good thing here, he has no symptoms. Luckily, in his annual executive checkup, there was a new nodule, which is 2.5 by 2.4 centimeters, suspicious lung nodule with spiculated margins in the right upper lobe. And he has access to PET, or positron emission tomography, which showed an avid, it lit up, the nodule lighted up with no activity found elsewhere in the body. So this means that the nodule is hypermetabolic, and it means that there must be something very, very actively happening inside of the nodule, or the buccal in the lung. So that is what was found in the PET. And luckily, there was no nodule or no activity of that kind in the other parts of the body. So what does this mean to us? It means to us that the activity, or the suspicious activity, is only there in the area of the suspicious nodule, and no spread, no metastasis, or no spread anywhere else in the body. Okay, so this is the CT scan. This is actually the patient CT scan here. You can see that I'll just use a pointer. There is a nodule seen in the right upper lung. Okay, and if you notice that there is no nodule found elsewhere, or no activity like that found elsewhere in the body. So for us, when we see that kind of patient scenario, no symptom, an activity, avid nodule, we actually, as pulmonologists, we do panic. We panic, and we actually make sure that all things are coordinated in a timely fashion, because we are dealing with a possibly resectable or possibly curable malignancy here. So if these are the kinds of patients that we encounter in our clinic, we do actually make sure that they follow up, they do it on time. Okay, so the clinical diagnosis is a pulmonary nodule of the right upper lobe, possibly lung cancer, which is an early stage lung cancer, which is stage 1. Versus, of course, if the PET, or the positron emission tomography, lit up or lighted up, it doesn't mean necessarily na cancer yun. So it can still be anything that is hypermetabolic or actively dividing, and TB is one differential as well. So for those of you who have patients who have PET lighting up elsewhere in the body, so do not assume that it is malignant until it is proven by a biopsy. Okay, so our dilemma for this case actually is, number one, do we do a biopsy, or do we check for the nodule if it's malignant or not? Number two is, do we do resect, or do we do outright resection, like we remove the nodule outright while it is still small? Or number three, we treat for TB first and then observe if the nodule will be enlarged or not, of course. Okay, so these are the three dilemmas. So these are the advantages of the biopsy. Either we do it, I personally do bronchoscopy, biopsy, and we use sophisticated equipment to do this, or transthoracic biopsy, wherein we puncture a needle from the chest wall to the nodule. Okay, so the advantages of bronchoscopy: it's minimally invasive, can be done as an outpatient here. It's less expensive and can direct us for the next steps. Okay, the disadvantages, of course, for a small nodule like 2 cm, we would not be 100% sure that we hit the nodule during the biopsy. So we have a chance that the biopsy will be a false negative biopsy, okay, especially if the nodule is very, very small, okay? It is still, even if it's minimally invasive, it is still associated with risk, like bleeding and pneumothorax, and can be expensive, no? Especially in our setting, we have the endobronchial ultrasound guided biopsy. It can be more expensive than the usual procedures, okay? Of course, the next option is we do nothing, like we do observe first and treat for TB and have the patient follow up. For me, personally, this is a very dangerous, very dangerous strategy to, if we do not have any diagnosis yet, or we suspect that it is probably malignant or TB. The advantage, of course, it is minimally invasive, actually no invasiveness, and it's less costly, but the disadvantage is actually the false diagnosis. No, we do not have any objective evidence that it is TB. We just assume, okay? It can be most of the time false, and by the time that the patient may follow up, we already lose the window. We already lose the window that we could have treated the patient. No? So that window is very important for us pulmonologists and oncologists now, because that is the time that we can intervene and remove the nodule. So if we treat and have the patient follow up, maybe at the next follow up, the tumor could have spread already to the other parts of the body. Okay, so this is actually the next, of course, that's the most radical, is to do outright open biopsy and resection, or remove part of the lung. So it can be both diagnostic. So the surgeon will do a biopsy first, and if it is malignant, will remove part of the lung. And it can be therapeutic. No? So when I say therapeutic, if it is malignant and remove the part of the lung, jackpot. Kumbaga, it is already a cure, and the patient would be very happy, and the prognosis actually, or the outcome, would be very good. The disadvantage, of course, it's not for everyone, okay? So not all patients are good candidates for open biopsy and resection. It's invasive, and it is associated significantly with complications. So this is actually a really delicate balance of doing invasiveness versus the benefit. No? So for this patient, actually, we did decide, since this patient is healthy, except for his smoking, no, and for the lung mass, of course, I personally decided that this patient is a good candidate for resection. So when we say resection, the upper lobe or the lobe of the lung was removed, and true enough, the biopsy was adenocarcinoma, which is a subtype of non-small cell carcinoma of the lung, and the surgeon took out some lymph nodes to sample, and then there were no spreads, and the patient was happy and discharged 4 days post-operatively. And in his follow-up to me recently, 6 months after, he was able to return to his previous job, and on surveillance, on checking PET, if there is spread to other parts of the body, actually, luckily, there is none. So this patient is lung cancer-free for 6 months already, and we assume, and we hope that he will remain so in the next years to come. Okay, so this is one of the examples that are, kumbaga, very luckily, serendipitously was detected, and then we came to the right decisions, and then had the correct or the proper management, and then the outcome is very good. No? So these are the cases that are, makes us clinicians very happy and very contented, no, that the outcome is very good. Okay, so the final diagnosis is a 1A, stage 1A lung adenocarcinoma, and the resection was curative. No? So this is one of the examples that I share with my students, with my fellows, with my trainees, that this lung cancer is not actually a death sentence. So it is actually a good, if you catch it early, there is a good outcome for this. No? So, but we have to remember that these are the, kumbaga, minority of the patients. No? If lung cancer will present, it would be some kind of a late stage. But for the patients that present as an early stage lung cancer, so I think the message here is really to act fast, to have it resected and to have it cured. No? So lung cancer, even though the patient population and the demographic of smoking and all the other cigarette smoking related diseases have increased, also lung cancer has also increased. No? So it's the most common cause of cancer death in the world. Okay, and in the Philippines, actually lung cancer is still here, one of the leading causes of cancer, and of course cancer death. No? So lung cancer is associated with grim prognosis, but do not lose hope because as I told you, there are actually a lot of good cases and good prognosis lung cancers here that we have. So non-small cell lung cancer is still the most common type of lung cancer. In the past, it was squamous cell carcinoma, but right now, actually, we see a lot of adenocarcinomas here, okay? Adenocarcinomas are now leading as the cause of non-small cell lung cancer. And now what's special about adenocarcinoma is because there are a lot of new, I think Dr. Rich King will discuss this later on. There are a lot of new treatments that can help achieve the target cure for the patients with adenocarcinoma. Okay, so survival rates are low in patients diagnosed with lung cancer. So 79, yun nga, as I told you earlier, 79% of patients present with regional or metastatic disease, but do not lose hope that 21% actually can be saved, no? And of course, the 79%, not all have bad prognosis. There are regional diseases that can still be cured, no? So there is still hope for them, okay? And actually, the metastatic disease, lung cancer actually have also a lot of options right now, okay? So the survival is 59% if it is localized, but it's still a good number. And we can actually increase this 59% if we really detect the lung cancer at a very, very early stage, like what we presented early on, okay? If it's regional or metastatic, regionally metastatic, like in the lymph nodes, the survival drops to 31%. So nag-half agad yung survival. And unfortunately, if it is metastatic, the survival is very, very poor with 5.8% of the patients surviving 5 years. No, so the goal here, I think the goal of the talk right now is to how to detect early stages lung cancer and to keep the survival very, very to a good level. Okay. So yeah, the majority of lung cancer present with regional metastatic disease, but do not lose hope. We can actually increase the proportion of patients who present early and can be cured. Okay, so the leading risk factor for lung cancer is not smoking, but can be developed, especially in females. It can develop in patients who have never smoked. No, so patients will come to us, hindi naman ho ako naninigarilyo, I have never smoked. Why did I have this lung cancer? So there are a lot of factors that can of course contribute to the development of lung cancer. One of them would be age, exposure to smoking, environmental exposure. Of course, the genetics of the patient can actually be contributory to the development of lung cancer also. Okay, so these are the common signs and symptoms of lung cancer. And it is very non-specific and open to misinterpretation. So symptoms of lung cancer usually do not appear until the disease is already at an advanced stage. No? So sometimes patients disregard their symptoms and then they just say, masakit lang likod ko, or umubo ako, baka it's probably a simple infection or viral infection. So these are the symptoms: cough, shortness of breath, unexplained tiredness, blood or hemoptysis, and chest pain. Unfortunately, these are late symptoms already. And sometimes if the patient has these manifestations already, the survival and the chances of cure are very, very poor. Okay, I'd like you to focus on the bullet at the bottom. In some cases, lung cancer is detected at an early stage. No, so these are the patients that are actually lucky enough, no? And some of the patients are actually very anxious, and then they consult at a early stage, and then they will actually be having a appropriate management already. Okay, so these are the lucky patients, and actually we can, no, hindi lang luck ang that drives this to come to us. They can actually increase the proportion of patients who present to us as unasymptomatic, no? I think Dr. Rich will be talking about, and I will be talking about screening of lung cancer later on. Okay, so the prognosis of lung cancer, I told you this earlier. So this is sadly a poor prognosis disease if detected late, no? But our goal And our goal and our advocacy in pulmonary medicine in PGH and in all the our societies in the Philippines is to increase this localized disease proportion. No? So 64% survival rate, we can actually increase the proportion of patients who present with localized disease and affect the outcome. Better. Okay, so this is the rough guide to treatment of lung cancer. If it is an early stage, we do surgery here. For local regional disease, we can do surgery plus medication like chemotherapy. And of course, for the late stage disease, surgery would not be an option. And actually, we give chemotherapy already. Okay, so this is what I was talking about. The surgical treatment of lung cancer is different, no? So we have to tailor fit the patient's capacity to undergo this, no? Mind you, hindi biro to remove a part of the lung, especially in a patient who is already dyspneic or who has already symptoms. But if the patient can tolerate a surgery, like a lobectomy to remove a whole lung lobe or pneumonectomy, we do it by all means. If the patient can tolerate it naman, and we do it by all means just to affect or to save the patient from metastasizing the lung cancer. Okay, so I think at this point in time, I will call Dr. Rich King to discuss one of the most important aspects of lung cancer management. As I told you earlier, we want really to increase the proportion of the patients who do present early on. So one of the strategies that we have devised, or the authorities have devised actually, is to screen for lung cancer. And this is one very interesting and one very affordable and I think very logical solution for the patients to present to us to detect early lung cancer. So Rich, the floor is yours.
So
Yeah,
the
we
case
can hear you.
presented a while ago really highlights really well the importance of early detection for lung cancer. Since the patient had stage 1 disease that was adequately treated with surgery, we expect a more favorable long-term outcome for this patient without him having to undergo any adjuvant chemotherapy or radiotherapy. But more often, the patients we encounter are diagnosed once they're already quite symptomatic, at which point they're more likely to be in the more advanced stages of the disease, where survival drops progressively with higher stages. But we have an opportunity for improvement here. We know who are those at high risk to develop lung cancer. There are tests available that can detect cancer even before symptoms develop, and there are treatments that can prolong survival and possibly offer a chance for cure. So in order for patients to have the best outcome, we want to be able to diagnose lung cancer as early as possible. And this is precisely the goal for many lung cancer trials that have been conducted worldwide. We see very clearly that without screening, less than a quarter of patients will have stage 1 disease at diagnosis, and there is consistent evidence showing a higher proportion of stage 1 cancer diagnosed when screening is performed. But does it actually improve survival? The most adequately powered study to answer this question is the NLST trial published in the New England Journal of Medicine in 2011. Here, more than 50,000 adults aged 55 to 74 with a 30-pack-year smoking history were either current smokers or are within 15 years from quitting were randomized to 3 annual screenings with low-dose CT scan of the chest compared to chest X-ray. Low-dose chest CT is more sensitive than chest X-ray, especially for smaller nodules, and allows us to characterize lesions, which is helpful in estimating the risk for malignancy. At the same time, it delivers a much lower radiation dose compared to a conventional CT scan. This trial demonstrated a 20% reduction in lung cancer mortality with low-dose CT and a 6% reduction in mortality from any cause. The trade-off is that patients who underwent low-dose CT were more likely to have suspicious findings detected during screening, and they would need close surveillance with more frequent imaging, or need a biopsy of a lung nodule. However, since the benefit was clearly demonstrated in this trial, low-dose CT is established as the modality of choice for lung cancer screening in this high-risk population. One common question is, will a chest X-ray suffice as a screening test? This has been tested also, most notably in the PLCO trial. This was conducted in a large population of more than 150,000 participants in the same age group as the NLST trial, but differs in that because this is a screening trial for 4 different cancers, they included both smokers and non-smokers. However, 20% of the participants who would have been eligible to the NLST inclusion criteria of 30-pack years of current or recent smoking. In the PLCO study, 4 annual screenings with chest X-ray was compared to no formal screening or usual medical care. And unfortunately, the trial failed to demonstrate a benefit for chest X-ray in terms of lung cancer mortality in both the overall population and the high-risk NLST eligible population. And there was only a marginal increase in the proportion of stage 1 cancer on diagnosis. Other screening strategies have also been investigated. One example, in Johns Hopkins and Memorial Sloan Kettering, they evaluated sputum cytology every 4 months. Another is more frequent chest X-rays every 4 months together with cytology done in the Mayo Clinic. Unfortunately, neither of these strategies led to any significant reduction in lung cancer mortality and have since been abandoned. Because of this, at present, the U.S. Preventive Services Task Force recommends annual LDCT for lung cancer screening. Note that the eligible population was updated in 2021 from the minimum age of 50 years with 30-pack years of smoking in the NLST trial, now expanded to at least 50 years with 20-pack years. And this is based on modeling studies that demonstrated sustained benefits with this expanded criteria, meaning more patients now stand to benefit from lung cancer screening. Please note that there is a qualifier with a recommendation that screening should be stopped once a patient has stopped smoking for 15 years or has limited life expectancy or will not be able to tolerate surgery. The Philippine Periodic Health Examination Guidelines for lung cancer screening mirror the USPSTF recommendations, but further add that those with a family history of lung cancer are also eligible for screening. This is in line with the observation that lung cancer in family members who are non-smokers is also a risk factor for the disease. However, it should be emphasized that there are actually many things to consider and discuss with the patient before we initiate them on lung cancer screening. The benefits, as we've discussed, include a 20% reduction in lung cancer mortality, and as a result of an earlier diagnosis, patients may be able to avoid complications of advanced disease and multiple rounds of treatment. Screening has also been shown to improve quality of life and help patients adopt healthy lifestyles, especially smoking cessation. There may also be instances where an occult but clinically significant condition such as coronary artery disease, breast cancer, or the like may be detected on CT scan. However, all these benefits should always be weighed against any possible harms associated with screening. For example, as the NLST trial has shown, a significant number would at some point have suspicious findings that would warrant a repeat scan every, say, 3 months or 6 months. So for these patients, it's no longer the annual LDCT, but more often than that. Some who may require a biopsy may also turn out to have benign findings. And conversely, it's also possible that despite an initial negative screen, a patient may develop advanced lung cancer before their next low-dose CT scan. Other possible harms include unnecessary anxiety and distress from having suspicious findings, complications from biopsies, radiation exposure that may contribute a very small but real increased risk of developing cancers, and of course, cost associated with repeat imaging, biopsies, pathology, etc. That's why it's very important to have a shared decision-making with the patient after careful discussion on all these elements. There are tools available that can help individualize our discussions with patients. This is one example of a lung cancer screening risk calculator accessible online. It starts with a check on whether the patient in question is eligible for lung cancer screening. And then the tool then provides feedback on what is the patient's risk of developing lung cancer in the next 5 years, what's their life expectancy without screening, and what's the number needed to screen to avoid one lung cancer death. And this provides a recommendation whether to encourage or discourage screening, or maybe somewhere in the middle, and decide based on the patient's preferences. It also provides a visualization of the benefits and harms of screening. How many similar patients would die of lung cancer in 5 years? How many would be saved with screening? How many would have false positives, and how many might have complications after invasive tests? All in all, this tool can help in making sure that the patient is making a well-informed decision regarding screening. It's also been shown that the success of a lung cancer screening program in terms of improving patient outcomes largely relies in a programmatic approach to the process. First, not only should the patient fit the eligibility criteria by age, smoking history, family history, we should also consider life expectancy, comorbidities, and the patient's own values. Is the patient medically fit for thoracic surgery? Would they consent to a biopsy if they found a suspicious lesion, or to a lobectomy for an early stage cancer? It should also be emphasized that screening is not a one-time activity, but a process that would require follow-up, especially since a change in the size of a nodule strongly affects the likelihood of a malignancy. As mentioned, we should involve the patient in the decision-making process after thorough discussion of the possible risks and benefits, and it would be very helpful to have a navigator who would help direct and follow up patients to avoid dropouts in the program. These patients should be offered smoking cessation services when warranted, especially since it's been tied to improved outcomes even after a cancer diagnosis. And there should be access to a high-quality, multidisciplinary cancer care team that can provide timely and effective evidence-based treatment. In the Philippines, there is a lung cancer screening program led by the Lung Center of the Philippines. They follow the eligibility criteria of the USPSTF and the PHEX. For non-smokers who develop cancer, their adult first-degree relatives are also eligible. A shared decision-making process is employed. The LDCTs are funded by the government and at no cost to the patient, and smokers are referred to a smoking cessation program. And there's also a patient navigator proactively following up on the patients. This program started in 2021, 2022, and so far they've enrolled more than 100 participants and have been able to diagnose a number of lung cancer cases in whom treatment has been initiated. Just this month, there's also been an update in the screening recommendations from the American Cancer Society. Now, even smokers who quit more than 15 years ago remain to be eligible for screening with annual low-dose CT as long as other eligibility criteria are met. This is again because recent modeling studies have shown cancer risk persists beyond 15 years, and the number needed to screen is preserved and not increased. But with expanding the eligibility criteria, more patients now stand to receive this benefit. How about lung cancer among non-smokers, which is also quite prevalent in the Philippines and other Asian countries especially? Being not included in the current eligibility criteria, we do still miss out on a lot of these patients. A prospective cohort in Taiwan enrolled non-smokers who are considered to be at high risk for lung cancer, namely those with a family history, which comprised half of the population, passive smoking exposure, TB and COPD, and indoor frying with poor ventilation. On the first round of low-dose CT scan, 17% were screened positive, and 2.6% of the entire cohort of 12,000 patients were found to have lung cancer. It was particularly high among first-degree relatives of lung cancer patients, hence giving us an insight on that perhaps there may be a reason to consider screening for these other high-risk patients. We await the long-term results of this study, and hopefully an RCT can be initiated to address this question. On a related topic, I'd also like to emphasize the importance of diagnosing lung cancer in a timely manner. As you know, symptom recognition can take quite a long time before a patient consults for respiratory symptoms. And there are several steps involved, from first X-ray and CT scan, biopsy, pathology, metastatic workup. And because there's so many hurdles involved, many patients, even those who initially present with localized disease, may convert to advanced disease by the time they're evaluated for treatment. A study done several years back found that among patients diagnosed with lung cancer, 46% were previously empirically treated for tuberculosis prior to referral to PGH for evaluation of a suspicious lung mass or nodule. Perhaps now that we have access to more sensitive tests for TB detection, such as PCR, we can further emphasize the importance of pursuing a bacteriologic diagnosis of TB. And from another angle, it's always a good idea to have an index of suspicion for cancer when it is appropriate, even in patients who are young and non-smokers. Hopefully, this can help us find more cases of early stage lung cancer to whom we can offer a chance for cure. So I now return the floor back to Dr. Ralph for the next case in our discussion.
Hi, Rich. Thank you very much for that very insightful talk on the screening of lung cancer. No? So, yeah, before we move on to my talk, actually, I'd like really to focus on this slide that the last slide of Dr. Rich. No? So, it's very, very important that if you find a patient with a lung nodule, you have to have a very high index of suspicion for cancer and do not assume that it is not cancer. And treat for other etiologies like TB or antibiotics or pneumonia and all that. You have to assume that it can be curable, no? So you really have to be very, very aggressive. I think that's the point of the talk now, to be very, very aggressive in the management of early stages of cancer. Now we move on to the second part of the talk here, wherein we will be having a short discussion on the more locally advanced lung cancer, which is the message for this part right now is it is not actually too late, no? Even if the cancer has spread to mediastinal structure, to the lymph nodes, or there are other already spread to the other parts of the body, it is never too late to tell us that lung cancer is already at too late or too hopeless for a cure, because even at the locally advanced stages, we can still cure lung cancer. Okay, so I'll present a actual case. Actually, this is our case with Dr. King. So we managed this patient maybe 3 months ago. She's a 34-year-old female with no known comorbids. She's a non-smoker and no respiratory symptoms, wherein she had a vague back pain on her as her symptoms. So at her chest X-ray, there's a solitary nodule at the left upper lung field, as you can see here with the arrow pointed. Okay, and the CT scan showed pulmonary nodule in the left upper lobe with suspicious pleural attachment. So this is the nodule that we are talking about, and unfortunately, it has attached the chest wall or to the pleura, and there's a suspicious lymph node at the aortic area. So if we would like to differentiate it in the first case, this patient right now has already started to spread. The cancer has spread to the regional area, to the lymph node, but not to the distant sites. Okay, and we did a PET CT scan, and the nodule here lighted up, and the lymph node and the mediastinal area also lighted up. So what does that mean for us? It means that the nodule would have some metabolic activity. It is actively dividing, and if that whatever that activity is has spread already to the lymph node here in the aortic area. That's what I was pointing about. And again, this is not malignant until proven by a biopsy. Okay, so this can still have some other differential diagnosis and not necessarily cancer. So our clinical diagnosis is a left upper lobe nodule with possible mediastinal involvement. And again, I would like to reiterate that even in these cases, a malignancy, even a young patient, non-smoker, female with no risk factor at all, no history of cancer in the parents or in the family, lung cancer should be top of our mind if we see a nodule and a possible spread. No? So TB is a secondary differential diagnosis here. So again, this would be the rough guide to treatment of lung cancer here, as what I've alluded to earlier. So this patient would probably fall into here the regional disease. So surgery is still an option, and of course radiotherapy and pharmacotherapy. Okay, so now our dilemma would be again like the same as in our first patient. Do we do biopsy plus the definitive treatment? Do we resect outright, or do we do a trial treatment with anti-TB medications and assess? I think as of this time, if you are listening to Dr. King and my talk earlier on, we would not even consider to do the third option, to do a trial treatment with anti-TB and reassess, because it might be too late. Now, lalo na this patient has already spread to the lymph node, and the golden period, the time that we have to intervene is shorter than the first case, okay? So this would be the options, no? So biopsy plus definitive treatment. Of course, for the biopsy, it's minimally invasive and it's less risky compared to the surgery. However, the disadvantage for a biopsy here would be resection is not considered for this case, and the potential for the complete removal or for the cure, possible cure of the tumor is not possible. Okay, so that's the main disadvantage of biopsy plus definitive treatment here again. So, I would point it out that we denied the patient of a possible curative option for this case, and that is not what we wanted. For the young patient, 34-year-old female with no comorbidities, she has a good life ahead of her. The plan actually is to achieve cure, no? So for lung cancer. So of course, again, I would like to skip this actually altogether because we do not want patients to have a trial and error of anti-TB treatment with medication, lalo with the nodules, lung nodules. Do not do that. That's my main advocacy, to not treat unless you have a proof, no, like you have a biopsy that it is TB or you have a gene expert that is positive. No, do not try to treat for TB first and return. And if the golden period and your time to intervene has already lapsed, it might be too late already. Okay, and as I showed it there, it's an unfair gamble for the patient if you do that. Okay, of course we have the most radical of all the treatment. We want to achieve cure, so we would want to achieve resection plus adjuvant treatment for this patient. Resection is still potentially curable, even if it has spread to the lymph node already. It is not, as I told you earlier, it's not too late. It's never too late for cure unless it has spread to metastatic or to the other sites already. Okay, the patient is young, no comorbidities, and is a good surgical candidate. And the main disadvantage would be, of course, it would be very invasive and expensive. But for these kinds of patients, we really want to push for cure. Okay. So again, luckily, the patient underwent VATS and thoracic surgery, and the lymph node was also resected together with the mass. So the tumor is 3 cm, and thankfully, there's only spread to one mediastinal lymph node, and the patient was discharged 4 days post-op, and I think the patient underwent adjuvant chemotherapy and radiation therapy, and I think as of this moment, there's no documentation of recurrence, and we are very happy that this young patient, this very, very productive patient, actually was spared of potential harm from early diagnosis. Okay, so lung cancer staging for this patient. So we talk about the primary tumor size, we talk about the regional lymph nodes and distant metastasis, of course. So for the first patient, I'd just like to read you through. The primary tumor is a small tumor, so it's less than 3 cm. And there are no lymph node spread and no distant metastasis, so that makes the first patient stage 1. But for the second patient right now, we're talking about something that spread to the mediastinal node. So it's an N2 disease and the patient is actually T2 already, like 3 to 3.5 centimeters. So the patient has a definitely higher stage than the first case. No, so this patient, although the patient is stage 3, it doesn't mean that it cannot be cured, no? So it doesn't mean that it's too late, no? So I think that's the mindset that we have to remember right now, that it's never too late until it has spread to the other parts of the body. And even if it has spread to the other parts of the body, there are modalities that can achieve a good outcome for the patients with lung cancer. So there. So the elements, how do we assess if the patient would be a good candidate for resection or removal of the tumor? Of course, the age and comorbidities, the lung function, we do calculate it by using sophisticated materials and a simple breath test. And of course, we want to refer the patient to the best surgeon that we know of, who has a lot of experience in resection of lung cancer, because the outcomes have been shown to be affected by the experience of the surgeon here. Okay, so I'd like to focus, just one of my last slides, to focus on the survival rates of resected lung cancers here. If the patient is stage 1, 1A or 1B, if we do chemotherapy plus surgery, actually the survival is not much different. But in the more advanced stages, in 2 and 3A that are resected, no, so chemotherapy or adjuvant therapy for lung cancer actually increases the survival. No? So this is like what I was telling you earlier, that there is a difference between the management of the two cases. This is the second case is a higher stage case, so there would be an additional treatment, no, aside from resection. And I think Dr. Rich King would be discussing it, would be discussing how to add on to the armamentarium that we have aside from resection. What do we add for the later stage lung cancer to achieve a better prognosis for that patient, for those patients?
So from an oncology perspective, in general, we consider giving adjuvant therapy, meaning after curative surgery, for tumors larger than 3 cm with high-risk features such as poor differentiation and vascular invasion. It's also recommended for disease that has spread to the lymph nodes. On the other hand, adjuvant radiotherapy is typically recommended for incomplete resections or positive margins of resection. Some patients may get the best benefit with a combination of chemotherapy and radiotherapy. So the benefit of adjuvant chemotherapy for lung cancer was established in 2004 by a study published in NEJM showing improvements in overall survival, disease-free survival with the addition of chemotherapy after surgery for stage 1 to 3 disease. Over the years, newer chemotherapy drugs have been developed, such as pemetrexed, docetaxel, gemcitabine, which, when paired with a platinum agent, such as cisplatin, led to incremental benefits in survival. Now, we are in an advent of precision medicine in oncology, where initially in patients with advanced and metastatic lung cancer, we saw significant benefits with targeted therapy. Targeted therapy pertains to treatments that target certain abnormalities in tumors that drive their continuous and uncontrolled growth that is characteristic of cancer cells. These therapies first demonstrated their clinical benefit in metastatic disease, and because of their success in that setting, they're now being tested for even for early stage lung cancer. One example is a drug called osimertinib, which is an oral medication that inhibits the epidermal growth factor receptor, or EGFR. EGFR is a protein on the surface of cells that normally helps the cell to divide and grow, and it is activated by the epidermal growth factor that's found in the surrounding area of the cell. When mutated, it functions similar to a switch that is always turned on, resulting in an uncontrolled growth of a cancer. So when we inhibit this mutated receptor with a drug like osimertinib, we may be able to limit that uncontrolled growth. True enough, a recent clinical trial found that patients with stage 1B to 3A non-squamous, non-small cell lung cancer with an activating EGFR mutation, when these patients were given with osimertinib after chemotherapy for a duration of 3 years, it led to an improvement in overall survival and disease-free survival, which are endpoints that have been previously difficult to improve in the previous years. Certain targeted agents are also being studied as a possible replacement to chemotherapy. An example is alectinib, which inhibits a different target, specifically ALK translocations. Patients with stage 1B to 3A non-squamous lung cancer with this type of mutation were randomized to receive either standard of care chemotherapy for 4 cycles or the oral drug alectinib for 2 years, and it was recently found that alectinib significantly improved disease-free survival at 3 years to 89% from 54% with chemotherapy. Another class of drugs are immune checkpoint inhibitors. Immune checkpoints are a normal part of the immune system. Since our own immune system can help in getting rid of cancer cells in our body, some cancers turn down this cancer-killing immune response by producing lots of PD-L1 that bind to PD-1 in immune T cells. Immune checkpoint inhibitors work by preventing this binding, in turn allowing our immune cells to kill cancer cells. There are a number of different immune checkpoint inhibitors that have been used in the adjuvant setting. One example is a drug called atezolizumab, which is a PD-L1 inhibitor, which when given to patients with stage 2 to 3A non-small cell lung cancer after curative surgery and chemotherapy, was also found to improve disease-free survival, especially so in cancers that on molecular testing have a PD-L1 score of 1% or more. Since the action of immune checkpoint inhibitors differ from conventional chemotherapeutic agents, the side effect profiles are different as well and are more related to the activation of the body's immune system, sometimes resulting in inflammation in different parts of the body. Commonly, these are tolerable to patients and can be adequately managed with supportive treatment, steroids, and other medications. So, as I've mentioned, there are already several immune checkpoint inhibitors that have been tested in the adjuvant setting for non-small cell lung cancer. And actually, some are given in the neoadjuvant setting, meaning pre-operatively. And this highlights the need for a good, a well-coordinated multidisciplinary team in order to be able to discuss and select which patients should derive benefit from systemic therapy first or systemic therapy after. And there are other improvements in other technologies related to cancer treatment, especially in radiotherapy. We are now increasingly able to provide doses that are conformal or are directed quite well to the area of the tumor, such that we are able to spare other areas of the body that are not affected by cancer. All of these improvements have given us slow but a continuous improvement in cancer survival over the past years. And again, I'd like to highlight the importance of a multidisciplinary team in order for us to be able to advocate and decide on the best possible treatment for each individual patient with cancer.
Yeah, thank you very much, Rich, for that very fruitful discussion. So I'd like to focus actually on the last slide. And I think this is one of the few things that are very important right now. And it's an in thing in diagnosis of lung cancer and the management of lung cancer is what we have a multidisciplinary team. No? So us pulmonologists are usually the first contact of the patient. We would be the ones to gatekeep what will happen or what would be the next management of the patient. So it's actually a really at the you have to have a good sense of direction and to have a good sense of what to do with the patient. So the pulmonologist is at the forefront, and of course we partner with surgeons, medical oncologists, and radiation oncologists, interventional radio to get get a good and a timely diagnosis of lung cancer, and we want it to catch it very, very early on. No? So, and then we refer them to oncologists, to our surgeon friends, if we think that they will really actually be beneficial for the patient. No? So, example, our surgeon, for the first two cases, we did refer it to surgeon because we thought that the lung cancer is still curable or resectable. And thankfully, the cases were resected very well. And for the second case, we did refer it to an oncologist. Like for this second case, I did refer it to Dr. King for adjuvant management. So I think the bottom line of the talk right now is actually the last few slides of Rich showed that the lung cancer is not, I have always reiterated this, that lung cancer is not a death sentence for the patient. It is actually curable. That day when we say lung cancer, goodbye. Right now it is curable, and we see a steady increase of cases of patients who have been cured for lung cancer, and that is still stage 1 and 2 that are potentially curable. Right now, we see stage 3s that do very, very well, of course, with the help of our surgeons and, of course, with the help of our oncologists and the technology and the medications that are actually available right now for adjuvant medical therapy. So I think that's the message that we have for today's talk, and I'd like to thank everyone. Dr. Rich King and and Dr. Sakdalan would be available for some question and answers. So I think thank you very much for listening to us. Thank you very much again.
Okay, thank you very much, Dr. Villalobos and Dr. King for that very enlightening presentation. It was very nice to hear clinical cases, actual clinical cases, and try and correlating it with discussions on cancer screening and early detection, as well as some updates on the management of lung cancer. So as we begin our open forum, we'd like to thank our sponsor, Roche, for helping make this webinar possible. So before I ask a few questions, I want to summarize some key messages that I got from your discussions. First is that screening for non-small cell lung cancer among high-risk patients, particularly the smokers, is important because of improved prognosis and improved survival outcomes if it is detected early, and that was really greatly emphasized in the examples that were discussed, the patient examples. And another important point that was stressed by Dr. Villalobos is that we should always have a high index of suspicion that a lung nodule that you might pick up on chest X-ray may be cancer, instead of just passing it off as something benign like TB. So it's very important to always have that high index of suspicion. Otherwise, it might lead to some delays in treatment. And then, as discussed earlier, also chest X-ray may not be really that effective in screening for lung cancer. Rather, it is low-dose CT scan that is effective in reducing mortality due to lung cancer, and it is preferred for those who are 50 years old and above with history of smoking and those with family history of lung cancer. So I think these are very important messages that need to be remembered by everyone in the audience. And towards the end, the latter part, there was also some discussion on the newer treatments on lung cancer available that are also effective in improving survival of patients with early stage lung cancers, maybe even up to stage 3. So I think the key here is prompt referral to an MDT or multidisciplinary team, because that is crucial in order for us to start treatment early and improve the outcomes of our patients. So thank you very much for all these important points that were raised. So I'd like to ask first Dr. Villalobos, regarding the multidisciplinary team, since I think most of the people here in the audience are primary care practitioners, and in the light of universal healthcare, what do you think would be the role of primary care physicians or GPs in the MDT as far as management of lung cancer is concerned?
Yeah, so good afternoon, everyone, and thank you for listening. Regarding the question, Sir Dennis, I think I would really like to focus and emphasize that the GP or the family practitioner, the internist, the general internist, are at the forefront of seeing our patients. And if ever they would detect someone who has possibly a lung cancer, I think the goal or the role of this is to promptly refer it to a pulmonologist or someone who is experienced in handling lung cancer. Maybe the oncologist may be the first one in the picture, but I think that's the goal, because if we are talking about lung nodule, we really have no time actually to waste. So I think the word there is prompt, or the key word there is to prompt referral to a pulmonologist or an oncologist, and then after that the oncologist or the pulmonologist will be the one to gather the MDT. I'd like to take an example for our institution in the PGH. Yesterday, I think there was an MDT of all the lung nodule cases. So in our clinics, we make it to a point that all lung nodules or all even incidentally discovered lung nodules without history of malignancy be referred to pulmonary medicine service for proper management. So I think that's the goal of the internists and the general practitioners for the UHC.
So it's really more of identification or picking up these problems and referring promptly to the experts. I think one of the common dilemmas, kasi I see here from the Q&A box, some of the attendees have raised the point of encountering this dilemma of how to deal with a lung nodule on chest X-ray. If the usual differential is TB versus cancer, how do you deal with that?
I think
Kasi very very common ng TB.
Yeah,
That's the major problem in our country, actually, in the Philippines, where TB is endemic, actually. And mind you, I think the main assumption there is that if you see a lung nodule, even if there are no risk factors for cancer, you assume that it is malignant until proven that it is not. So that's how we do it. So if we see a nodule, of course, we do sputum tests, we do CT scans and all the workups to check if it's malignant or benign. But until we get a biopsy, sir, that it is benign or malignant, we really cannot say. So the goal there is really to pursue a biopsy, and then the biopsy should be definitive. And that would be the first thing in the pathway to diagnose lung cancer. So it's not correct if we assume that it is TB unless we get a positive gene expert or a positive, quantiferon and all that. So it's really not correct to assume that it is TB based on imaging alone. So yun nga, the goal is to assume that it is malignant until proven otherwise.
Okay. But in some cases, patients are treated for TB and then that nodule disappears from the X-ray. Can you safely assume that parang retrospect na lang, can you safely say that this is just TB, or should you still consider lung cancer?
Well, there are, kumbaga, I may say these cases are the exceptions, no? Because maybe it's just lucky that they had been treated for TB and then the nodules disappear. And we can do a follow-up CT scan maybe to be sure that the nodules are really absent, because sometimes an X-ray cannot be as what Dr. Rich has mentioned earlier, even in the early stage nodules cannot be very, very accurate. So I think a CT scan should be done to follow up the nodules who have been previously treated for TB. Okay. But we can assume, sir, for the question, we can assume that probably this is TB, but until we get a CT scan that indeed the nodule has disappeared, so that is probably the safer way to do it.
Rich, any other thoughts or comments?
Yeah, same thoughts for me as well. I think for these patients, it would be most important to follow these up and to make sure that there really is no indolent cancer or something hiding aside from the TB.
Yeah. By the way, Dr. King, you were discussing screening earlier, and you've discussed about screening for cases of patients, especially the high-risk patients, the smokers. No? But we do know that we get a lot of cases of never smokers who develop lung cancer. How do you reconcile this? Or what can we do at this point, since you mentioned that there's really not much evidence yet that low-dose CT can be applicable for non-smokers?
One thing we should always keep in mind is that cigarette smoking is not the only risk factor for lung cancer. Air pollution is another one, other occupational exposures, even radon gas, which is available, which can be undetected, can be left undetected, is also a risk factor for lung cancer. I think what's most important here is once these are detected, we should be able to act accordingly. If a biopsy is warranted, do it in the earliest time as possible. We do not have a screening for lung cancer using chest X-ray, but actually annual chest X-ray is part of the recommendations for PHEX for tuberculosis. So there are actually lots of cases wherein a chest X-ray done for other reasons would reveal a nodule, and this would be a good opportunity for us to catch these patients.
Thank you. So I think there really needs to be a lot of research to be done for this patient, because we're just really limited to X-ray for cases of patients who are not non-smokers and get work for other reasons.
For the other high-risk populations, aside from the smoking, I think the best evidence that we can have is the one I showed a while ago, which is the TALENT study in Taiwan, which included non-smokers in that population.
That's right. And so we were just talking about risk factors, no? Other than smoking. There's some questions here about vape. What's your take on this? Does this contribute to lung cancer?
Because it would take a number of years before cancer would develop, we really do not have very strong evidence at this point. But besides that, we do know that the liquids used in vape do have cancer-causing compounds. So we know from insight that these patients are being exposed to certain carcinogens. So we are only really awaiting the data, the long-term data for these studies. But at this point, the best evidence that we have is to be able to relate that these the vaping liquids can have cancer-causing substance included in their formulations.
I'd like to add on vape, sir. Because we are really anti-cigarette smoking, and it's also safe that we are anti-vaping. So it's not just cancer that is being caused by vape. There are other diseases that as early as now has been proven to be caused. So there's what we call EVALI, or the associated lung injury from vaping. We also have data that vaping has caused lung obstruction or exacerbates these diseases. So it's really not just cancer that's being harmed, the harm or cause of vape, but there are other diseases, and we do not recommend for the cigarette smokers to go to vape or to start vaping at all. So it's safe to say that vaping is also the same as cigarette smoking as early as now.
Okay, so thank you very much for stressing that. No? So as much as possible, let's try not to start smoking. And if you, we really do recommend to stop, no, because of the effects of these risk factors. So anyway, we are bound by some time constraints, so we need to wrap up the open forum. So sorry about that. If you have other questions. However, if you want to receive more information about lung cancer screening and early detection, please use the QR codes that will be flashed in a while. Maybe we can have it on screen. Yes, please use this QR code so Roche can send you some relevant materials on lung cancer screening and early detection. Once again, thank you very much, Dr. Villalobos and Dr. King. We're really very grateful for your time and expertise, and present you your certificates of appreciation. So you'll receive them through email. Thank you very much. So this is for Ralph, and for the next one is for Rich. Okay. So thank you again very much for your time spent with us. So Class 1998 would also like to thank those who helped make this webinar possible. The University of the Philippines, Manila, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, the UP Information Management Service, and our sponsor for this webinar, Roche. We invite all our viewers to join the next webinar on mini laparoscopic surgery. Our expert speaker will be my classmate, Dr. Deo Reyes, Director of the Medical Cities CASTI, or Center for Advanced Surgical Skills Training Institute, and Medical Director of the Sacred Heart Hospital of Malolos. This webinar will be held on November 17, Friday, also at 12 noon. You can use the same Zoom link to register in advance, or use the QR code shown here. Our class is also inviting everyone to the annual UPMAS Golf Tournament on December 11 at the Ayala Greenfield Golf and Leisure Club. I think this is in Calamba. This exciting golf event will include lunch, giveaways, and a raffle, among other highlights. Interested players may register by scanning this QR code or typing bit.ly/upmasgolf in your browser. To receive your attendance certificate, kindly answer the evaluation form, which you can access through this QR code, and we will also post the URL in the chat box now. You will be able to receive your attendance certificate after answering the evaluation form. Please ensure that the name you enter in the form is the name format that you want in your certificate. See you next time as we continue to unlock knowledge for primary care workers and allied medical professionals. God bless and stay safe, everyone. Thank you.